Lecture 2 transcript. Failed induction as a biologic trial. This second lecture is about failed induction, but the real subject is diagnostic honesty. The phrase failed induction is often born in a tired room. The patient has been admitted for many hours, the family has watched the monitor long enough to know its sounds, the midwife has titrated oxytocin, the resident has examined the same cervix more than once. The day team has become the night team, or the night team has become the day team. Someone says, with understandable fatigue, she has been here forever. That sentence is human. It is not a diagnosis. Failed induction is not hospital duration. It is not emotional duration. It is not the number of vaginal examinations, the number of sign-outs, or the number of hours since admission. It is a judgment about whether an adequate attempt to produce active labor has occurred, and whether continuing that attempt remains safer and more rational than delivery by cesarean. The distinction matters because an induction can be long for several different reasons. It can be long because the cervix was not ready. It can be long because the uterus has not yet generated an effective contraction pattern. It can be long because membranes are still intact and the presenting part is not applying itself efficiently to the cervix. It can be long because the fetus or mother no longer permits patience. It can also be long because the team is calling preparation failure before the biology has had a fair trial. Those are different clinical states. In Lecture 1, we treated normal labor as physiology, mechanics, measurement, and judgment. Failed induction requires the same discipline. It is not a single clock. It is the interpretation of cervix, myometrium, membranes, fetal status, maternal status, and indication for delivery. Begin with what induction is asking the body to do. Spontaneous labor is not merely spontaneous contractions. It is a coordinated transition in which the cervix becomes soft and distensible, the uterus becomes increasingly responsive and coordinated, the membranes and decidua participate in prostaglandin signaling, and the fetal presenting part begins to transmit force onto the cervix and pelvis. When we induce labor, we are not simply substituting a medication for nature. We are trying to assemble, from the outside, enough of that biological system to make vaginal birth possible. That is why the cervix is not a preliminary detail. It is one of the central organs of the induction. A cervix with a low Bishop score is not just unfavorable as a label. It is tissue that has not yet acquired the physical properties required for efficient dilation. Gabb describes cervical ripening as softening and distensibility produced by remodeling of the cervical extracellular matrix, enzymatic dissolution of collagen fibrils, increased water content, and chemical changes driven by hormones, cytokines, prostaglandins, and nitric oxide pathways. This is not decorative pathophysiology. It explains why a cervix can be painful, manipulated, and exposed to contractions, yet still not open efficiently. The Bishop score is a crude bedside language for that tissue state. It asks about dilation, effacement or length, station, consistency, and position. In more physiologic language, it asks 5 questions. Has the cervix begun to open? Has it been taken up and shortened? Has the fetal head descended enough to apply useful pressure? Has the cervix softened? Has it moved from posterior to a more anterior alignment, where uterine force and fetal pressure can be transmitted more effectively? The numbers are important, but they should be learned as biology made visible. A Bishop score of 6 or less is an unripe or unfavorable cervix. A Bishop score of 8 or more is a favorable cervix. At that level, the likelihood of successful induction becomes similar to spontaneous labor. Gabby emphasizes that cervical status is one of the most important predictors of induction success, and that low Bishop scores are associated with higher failure and cesarean rates, especially in nulliparous. In one large nulliparous comparison, cesarean rates were almost doubled when induction occurred with Bishop scores below 5 compared with scores of 5 or higher. That does not mean a low Bishop score forbids induction. It means the induction must be understood as a biologically harder task. If delivery is medically indicated, the indication may still require induction even when the cervix is unripe. But the team must then respect what it has chosen. It is first trying to make the cervix inducible. That sentence deserves to be heard slowly.
An unripe cervix induction begins as preparation before it becomes a true test of labor. Now bring oxytocin into that physiology. Oxytocin is a remarkably powerful uterotonic, but it is not a good cervical ripening drug. Gabby describes oxytocin as a polypeptide hormone whose synthetic form is identical to the endogenous posterior pituitary hormone. It acts through myometrial receptors, G-protein-coupled signaling, intracellular calcium release, extracellular calcium entry, and contraction of uterine muscle. Its clinical advantage is controllability. It is given intravenously by infusion pump, has a short half-life of roughly 3 to 6 minutes, and reaches steady state after about 30 to 40 minutes following initiation or dose change. That pharmacology is clinically beautiful because it gives us a titratable instrument. We can increase force, we can reduce force, we can stop the infusion when uterine activity becomes excessive or the fetal heart tracing deteriorates. But the same pharmacology also warns us not to ask oxytocin to do a job it is poor at doing. Oxytocin can make the myometrium contract before the cervix has remodeled enough to yield. This is one of the central ideas in failed induction. If the cervix is firm, posterior, long, closed, and high, oxytocin may create real contractions and real pain without creating efficient dilation. The monitor may look active. The patient may feel very much in labor. The team may become impatient because activity is visible, but activity is not the same as effective cervical change. Gabby explains why oxytocin works better for augmentation than for induction with an unfavorable cervix. Myometrial responsiveness to oxytocin increases with advancing gestational age, and it increases rapidly once spontaneous labor begins. Oxytocin is effective in women with a favorable cervix, but it is less effective as a cervical ripening agent. Trials comparing oxytocin alone with prostaglandin methods in unfavorable cervices repeatedly show the same physiologic lesson. Prostaglandins are better at preparing the cervix, while oxytocin is better at driving uterine activity. The Israeli induction position paper makes the same bedside distinction. When the cervix is ripe, induction can proceed with amniotomy, intravenous oxytocin, or both. When the cervix is unripe, cervical ripening is indicated, using mechanical methods, pharmacologic methods, or sometimes a combination. In women with low Bishop scores, oxytocin is less effective than vaginal or cervical prostaglandin E2 for the ripening problem. So before a clinician says failed induction, one prior question must be answered with precision. Failed at what stage of the process? If the cervix is still being ripened, the induction has not yet necessarily failed. The team may need to change method, repeat a method, combine mechanical and pharmacologic strategies where appropriate, reassess safety, or decide that the original indication now requires delivery. But the time spent ripening the cervix is not the same thing as the diagnostic trial used to declare failed induction. The sources are quite explicit on this point. The Israeli position paper states that time spent on cervical ripening, mechanical or pharmacologic, is not counted in the definition of labor induction failure. The Spong workshop definition and Gabby's discussion make the same conceptual move. The diagnosis comes after adequate time for ripening and active labor development, not during the biologic preparation itself. Now, examine the ripening methods by mechanism. Mechanical cervical ripening with a balloon catheter is not simply a device placed in the cervix. It applies local pressure at and beyond the internal os, creating physical dilation and likely stimulating endogenous prostaglandin release. Its appeal is not mystical. It is local, mechanical, inexpensive, relatively simple, and in the Israeli position paper, it is described as effective with a lower side effect rate than pharmacologic methods. GBS carriage is not a contraindication to catheter use. A history of previous C-section is not a contraindication to catheter use. That last statement matters because induction after previous C-section is sometimes taught as though the only safe thought is avoidance. The real clinical world is more careful. A uterine scar changes the acceptable methods and the risk conversation, but it does not abolish the possibility of induction as a category. Mechanical methods and oxytocin may be used in carefully selected patients, while prostaglandin choices become much more constrained. Prostaglandins solve a different part of the problem. They participate in the connective tissue changes of cervical ripening, collagen disorganization, increased submucosal water, softening, effacement, and dilation. This is why prostaglandin E2 can reduce the chance that the cervix remains unfavorable and reduce the need for oxytocin. This is also why prostaglandins have a uterine activity cost. They do not only soften tissue, they can stimulate uterine contractions, and the price of that stimulation is tachysystole, sometimes with fetal heart rate changes. The Israeli paper is very direct about this trade-off. Vaginal PGE2 increases vaginal delivery within 24 hours, reduces the need for oxytocin, and reduces cesarean rate compared with placebo or expectant management, but it increases uterine tachysystole, with or without fetal heart rate changes. Vaginal PGE1, misoprostol, is effective and may have high rates of vaginal delivery within 24 hours, but it is associated with higher tachysystole and increased meconium in the comparisons described there. The same paper states that PGE1 is absolutely contraindicated after previous cesarean.
Gaby is even more broadly cautious about prostaglandins in a prior uterine scar, including prior C-section or myomectomy, because of the association with increased uterine rupture risk. The practical lesson is not merely know the contraindication. The lesson is to understand the mechanism of harm. A scarred uterus has a region of altered tensile strength. A drug that can increase uterine activity and make contractions excessive may convert a useful induction force into a dangerous stress on the uterine wall. This is also why oxytocin and prostaglandins must not overlap casually. The Israeli paper states that oxytocin and prostaglandins should not be combined, and that oxytocin should wait according to manufacturer instructions, because one potentiates the other. The local Pitocin protocol gives practical intervals. After propus removal, Pitocin may be initiated after 30 minutes. After Prostin gel, after 6 hours. The point is not bureaucratic spacing. It is pharmacodynamic respect. If prostaglandin effect is still active and oxytocin is added, the uterus may receive two converging signals toward excessive activity. Now, connect excessive activity to fetal physiology.
The fetus does not receive oxygen during labor as a continuous, unchanging stream. Uterine contractions transiently reduce uteroplacental perfusion. A healthy fetus with reserve tolerates that intermittent stress because there is recovery time between contractions. Tachysystole shortens recovery time. If contractions are too frequent, too long, or too close together, the placenta may have less opportunity to restore fetal oxygenation between episodes of uterine pressure. This is why tachysystole is not just a monitor word. Gaby uses the standardized definition, more than 5 contractions in 10 minutes averaged over a 30-minute window. The local Pitocin protocol also flags contractions lasting 2 minutes or longer, and intervals shorter than 1 minute, even when contraction duration is otherwise normal. These definitions are attempts to protect fetal reserve and maternal uterine safety. If uterine activity becomes excessive, oxytocin must be reduced or stopped. If there are prolonged or recurrent fetal heart rate decelerations, oxytocin must be stopped and the physician notified. If uterine rupture is suspected, oxytocin must be stopped immediately. So an adequate induction is not simply we ran Pitocin. It is oxytocin used in a monitored, interpretable, physiologically tolerable way.
The local protocol makes this operational. A physician orders Pitocin. The midwife executes the protocol. Both are responsible for uterine and fetal monitoring. Oxytocin must be administered by pump, not by uncontrolled infusion. Continuous fetal monitoring is mandatory.
The protocol gives different starting and maximum doses by parity and uterine scar risk. Higher starting and maximum rates for nulliparous, lower for multiparous, and lower still for grand multiparous or patients after previous cesarean. After completion of 1 liter of oxytocin solution, the decision about surgery, discontinuation, or continuation belongs to a senior physician. That local detail belongs in a lecture on failed induction, because adequacy is not an abstract evidence word. Adequacy depends on a real trial that could be observed, titrated, interrupted for safety, and interpreted. Now we turn to rupture of membranes. Amniotomy is often taught as a procedure. It should also be taught as a change in the physics of labor and the meaning of the clock.
With intact membranes, the fetal head may not transmit pressure to the cervix in the same way. The amniotic sac can distribute force. Once membranes are ruptured, the presenting part can apply itself more directly to the cervix and lower segment. That is one reason amniotomy can shorten labor. ACOG recommends amniotomy for patients undergoing induction or augmentation to reduce labor duration. In the induction studies it summarizes, early amniotomy shortened time to delivery, including an approximately 5-hour shorter induction to delivery interval in one systematic review after cervical ripening, without increasing cesarean delivery or major maternal or neonatal complications in those data. But amniotomy is more than acceleration. It is also diagnostic clarification. Once membranes are ruptured and oxytocin is being administered, the clinician has moved closer to a complete induction trial. The uterus is being stimulated. The cervix has had whatever preparation was chosen. The presenting part can act more directly on the cervix. The room is no longer judging the patient from the admission clock or the ripening clock. It is judging a more meaningful physiologic test. That is why so many definitions of failed induction require rupture of membranes if feasible. Now, let us reconcile the definitions carefully.
ACOG's current clinical guidance is that if maternal and fetal status remain reassuring, cesarean delivery for failed induction in the latent phase can be avoided by administering oxytocin for at least 12 to 18 hours after membrane rupture before deeming the induction unsuccessful. The decision to continue beyond 18 hours is individualized according to clinical characteristics, patient preference, and discussion of risks and benefits. That 12 to 18-hour range is not arbitrary. ACOG emphasizes that induced labor has a longer latent phase than spontaneous labor, while the active phase becomes similar once active labor is reached. Several studies show that a meaningful proportion of patients still in latent induction after 12 to 18 hours will deliver vaginally if induction is continued. In one cited cohort of more than 10,000 nulliparous inductions, 96.4% reached active phase by 15 hours, yet more than 40% of those whose latent phase lasted 18 hours or more still delivered vaginally. This is the evidence that protects patients from premature cesarean. A patient can look discouraging and still be on a path to vaginal birth. If mother and fetus are reassuring, the fact that the latent induction is long does not prove failure. It proves that induction can be biologically slow before active labor declares itself. Now compare SPONG and GAB.
The NICHD, SMFM, and ACOG workshop, summarized by SPONG, proposed a more conservative definition. Failed induction should be failure to generate regular contractions, approximately every 3 minutes, and cervical change after at least 24 hours of oxytocin administration, with artificial rupture of membranes if feasible. GABI teaches the same key principle. No universal standard exists, but adequate time for cervical ripening and development of active labor must be allowed before diagnosing failed induction. GABI also notes that experts have proposed waiting at least 24 hours in the setting of both oxytocin and ruptured membranes. This should not be taught as a crude contradiction between 12 hours and 24 hours. The better reading is layered. The 12 to 18-hour ACOG frame is a current minimum threshold for many reassuring latent inductions after rupture and oxytocin. The 24-hour SPONG and Gabby frame is a cesarean prevention conscience. It reminds the clinician that older, short thresholds created unnecessary first cesareans, and that the cost of the first cesarean extends beyond today's delivery. A first uterine scar changes the next pregnancy. It changes counseling about TOLAC and VBAC. It increases the future relevance of placenta previa, accreta spectrum, adhesions, operative injury, hemorrhage, and uterine rupture. The Israeli position paper adds the local operational layer.
It defines failure of labor induction as failure to achieve regular contractions and cervical changes after at least 12 hours of Pitocin administration, combined with artificial rupture of membranes as early as possible. Because rupture is a significant part of the definition, it says the duration of ruptured membranes should preferably be at least 24 hours. It also states that time spent on cervical ripening with mechanical or pharmacologic methods is not counted in the definition of induction failure. That is a sophisticated definition, if read correctly. It does not say that every patient must be forced through a fixed 24-hour ruptured membrane interval, regardless of infection, fetal status, or maternal disease. It says that rupture is central to the diagnostic trial, and that if you are going to call the trial failed, you should prefer that the ruptured membrane condition has had enough time to be meaningful. It also says after failure is suspected, the indication for delivery and the methods already attempted should be reevaluated. Options include continuing induction with other methods, temporary cessation, or cesarean. Notice the maturity of that wording. Failed induction is not an automatic command. It is a point at which the clinician reevaluates. Now place this beside active phase arrest. This distinction is essential. Before 6 centimeters, the patient is not managed by active phase arrest rules. ACOG recommends 6 centimeters as the start of active labor for management purposes. In induced labor, the latent phase is longer than spontaneous labor, but the active phase is similar. Therefore, before 6 centimeters, the problem is not active phase arrest. It is prolonged latent induction, inadequate cervical ripening, inadequate uterine activity, inability to rupture membranes safely, maternal-fetal deterioration, or eventually failed induction. After 6 centimeters, with ruptured membranes, the diagnostic language changes. Now, ACOG's active phase arrest definition becomes relevant. No progression in cervical dilation despite 4 hours of adequate uterine activity, or 6 hours of inadequate uterine activity with oxytocin augmentation. The 200 Montevideo unit threshold used for adequate uterine activity is historically important, but as Lecture 1 emphasized, it comes from limited observational data and should be used as a clinical approximation, not as a sacred physiologic boundary. The clinical habit is this: name the phase before naming the failure. A patient at 4 or 5 centimeters after induction may be profoundly uncomfortable and may have been in the hospital for many hours. But if she has not reached the active phase threshold, do not call active phase arrest. Ask instead whether she is still in cervical preparation, prolonged latent induction, or a failed induction trial after adequate rupture at oxytocin under reassuring conditions. Now let us apply this to a real sequence. A nulliparous patient is admitted at 41 weeks and 2 days. Her dates are reliable. The cervix is closed, long, posterior, firm, and the head is high. Her Bishop score is 3. The fetal tracing is reassuring. A balloon is placed. She has cramps through the night. She is tired. The cervix becomes 2 centimeters, softer and less posterior, but she is not in active labor. This is not failed induction. This is the biology the sources warned us about. The cervix was unripe. The work of the night was not wasted because the dilation number remained small. Some of the work was tissue work, softening, shortening, alignment, and the beginning of dilation. The next clinical questions are about method effectiveness, pain control, fetal status, maternal status, infection risk if membranes are ruptured, and whether to continue or change the ripening strategy.
The diagnosis of failed induction has not yet earned its place. Now, imagine that the cervix becomes more favorable. Membranes are ruptured, oxytocin is running, the tracing remains reassuring. Contractions become regular, several hours pass, and she remains at 4 to 5 centimeters.
Now the team is in a different conceptual space. The relevant clock is no longer admission time or ripening time. It is rupture plus oxytocin, interpreted under maternal and fetal reassurance. The patient is still not in active labor by the 6-centimeter management threshold, so this is not active phase arrest. It is prolonged latent induction. If oxytocin has not yet been administered for at least 12 to 18 hours after rupture, ACOG would generally protect her from being labeled unsuccessful, assuming the clinical situation remains reassuring. If the trial extends farther, Spong and Gabby remind us to consider the 24-hour frame as the more conservative cesarean prevention standard. But now change one fact. The same patient is being induced for preeclampsia with worsening severe features, or for fetal growth restriction with deteriorating testing, or she develops fever, uterine tenderness, and a tracing that is no longer reassuring. The clock does not disappear, but it loses its authority as the main question. The main question becomes whether continued induction remains safe and whether the indication for delivery has become more urgent than the hope of vaginal birth. This is why diagnostic patience must never become passive delay. Patience is appropriate only when it is biologically and clinically justified. A long induction with a reassuring mother and fetus is one problem. A long induction with worsening maternal disease, infection, or fetal compromise is another. The first may need time. The second may need delivery. The post-date protocol teaches the same balance from the other side. Post-term pregnancy is defined as 42 weeks or more. The protocol emphasizes that accurate dating matters because many suspected post-term pregnancies are dating errors. But when pregnancy truly advances, waiting is not harmless. Fetal risks rise. Perinatal mortality is higher than at term and rises further by 43 weeks. Meconium aspiration, placental insufficiency, oligohydramnios, macrosomia, dysmaturity, abnormal monitoring, and labor dystocia become more relevant. The local protocol recommends offering induction beyond 41 weeks, induction at 42 weeks, and immediate induction if NST or AFI becomes abnormal during expectant management. That means the resident must hold two forms of discipline at once. Do not call failed induction too early. Also, do not hide behind the clock when the reason for delivery is becoming stronger. Now return to the numbers, but now with their meanings attached. Bishop score 6 or less means the cervix is unripe. The induction begins with a tissue preparation problem. Bishop score 8 or more means the cervix is favorable. Induction success approaches spontaneous labor because the cervix has already entered a more labor-ready state. After rupture of membranes and oxytocin, with reassuring maternal and fetal status, ACOG asks for at least 12 to 18 hours before deeming latent phase induction unsuccessful. The Spong workshop and Gabe preserve the conservative frame of at least 24 hours of oxytocin, with rupture if feasible and with cervical ripening time excluded. The Israeli position paper defines failed induction locally as no regular contractions and cervical change after at least 12 hours of Pitocin, combined with artificial rupture as early as possible. Because rupture is central, ruptured membrane duration is preferably at least 24 hours. Ripening time does not count. Tachysystole means more than 5 contractions in 10 minutes, averaged over 30 minutes. Locally, also respect contractions lasting 2 minutes or longer, or less than 1 minute between contractions. These are not mere monitoring trivia. They are the physiologic warning that uteroplacental recovery time may be shrinking. Oxytocin reaches steady state after about 30 to 40 minutes and has a short half-life of about 3 to 6 minutes.
That is why dose changes should be given time to declare themselves, and why stopping the infusion can rapidly reduce uterotonic pressure when safety requires it. Now we can say the final clinical synthesis. Failed induction is not the diagnosis of a long day. It is the diagnosis of an adequate attempt that has not produced active labor after the cervix has been prepared as needed, after membranes have been ruptured when feasible, after oxytocin has been given for a meaningful interval, and only while maternal and fetal conditions allow the clock to matter. Before you say the words, ask the disciplined questions. Was the cervix unripe? And if so, was ripening actually the work being done? Were the membranes ruptured when safe and feasible? Was oxytocin given long enough after rupture to make the trial interpretable?
Were contractions regular and clinically meaningful without becoming unsafe? Is the patient still before active labor, or has she reached the 6-centimeter threshold where active phase arrest rules apply? Are mother and fetus reassuring enough for diagnostic patients to remain ethical? And finally, is the original reason for delivery stable enough to permit more time? That is the beauty of the subject. Failed induction is not a number pasted onto exhaustion. It is physiology, pharmacology, mechanics, epidemiology, and maternal-fetal judgment brought together at the bedside. When you diagnose it well, you are not merely reducing cesareans. You are respecting the biology of labor, the safety of the fetus, the future reproductive life of the patient, and the intellectual integrity of obstetrics.